Namaste. First of all, I'd like to thank NHRC for providing me this opportunity to share my presentation in this conference. My presentation entitled is Generation and Use of Gender and Social Stratifies in Information Management System in Nepal. So as we know that Health Information Management System is the main information platform existing in the country to record health service utilization data. And the evidence suggests that more than 50% of the health care is sorted primarily through the private health facility, which also include poor and excluded group. And gender and social inclusion are well adapted in the country. However, the implementation of the gender and social stratifier are mixed, and studies suggest that neither public or private health facility have systematic access with international perspective, so hence the gap in knowledge exists. So these are the objectives of my study. The first objective is to determine what the gender and social stratifier are incorporated in HMIS and IMIS of the private sector. And the second objective was to explore the use of IMIS to inform gender and equity dimension and healthcare planning, and also identify the gap in the use of evidence. And finally, the third objective was to develop the framework that inform gender and intersectionality dimension in MIS for evidence-based decision making. So methodology was a cross-sectional study, exploratory study, which was mix of the qualitative research and the document review. Regarding quality study, we conducted KII case study and review of MIS in two public and private health facility, which was conducted in Chandragiri municipality and Kathmandu municipality. And for the document review, this was the document that were reviewed for the desk review. So this is the study approach. The first objective was to determine whether gender and intersection stratifier are incorporated in the existing MIS in the public and private sector. For this objective, the method used was desk review of existing IMS policy and the review of DIS stacker. And the expected outcome was to understand the policy provision and availability of different intersect stratifier in MIS. The second objective was to explore the use of MIS to inform gender and equity dimension in health planning and what are the gaps in various level of evidence. For this objective, the method used was KIA and the case study. And the outcome was to understand of existing practice, gaps, and factor associated with the disaggregated data in decision making. The third objective, which was to develop framework that inform gender and intersectionality dimension in MIS for evidence-based decision making. For this objective, the method used was consulting with the technical working group of the municipality and consulting with HFOMEC. So this helps to co-produce of the framework to inform policy and practice through gender and intersectionality lens. So what are the findings from the desk review? The findings from the desk review show that there is a reflection of importance of disaggregated data in national strategy and plan. However, only few policy mention about the inclusion of gender and different intersection in the information system. For example, the health sector information system talk about the need for analysis and dissemination of the disaggregated information by health facility and the requirement of disaggregated data. And the document also informed that there is a lack of coordination of public and private health facility in the collection of analysis of the data. Similarly, the manual for HMS data analysis say that the program manager should focus on variety of service from different perspectives such as age, caste, sex, geography for analysis the data. Similarly, the National Health Policy emphasizes on equitable service delivery. It ensures that health service provision by the state are accessible to poor, marginalized, and vulnerable community based on equality and social justice. The National Health Policy also mentions that decision making and the program formation should be linked with demographic data. And the Nepal Health Sector Strategy also mentioned to improve the health status of the people through the accountability and equitable health service delivery system. It also emphasized equality service delivery utilization, service delivery and demand generation to undeserved people, including the urban poor. So the finding of the review of the document and HMIS, most of the HMIS recording form, generally they collect the data. They collect data on age, gender, ethnicity, and address of the patient. However, there is inconsistency in HIV recording form. For example, in the case of TB and HIV, they collect more stratified data. And the national surveys such as NDHS, mixed and step survey, they collect data disaggregated by gender and social stratifiers such as age, education, wealth content, geographical location, and they also present the data by the social stratifier. So this is the example of intersectional variable that is included in HMIS. This is the HMIS number, this is the name of the register, and this is the information that is collected from the different register of HMIS. So besides this, we also observed the information management system of private hospital. We found that all private hospitals record name, age, address, and contact number, and all private hospitals, they use HMS for reporting and GIS tracker for reporting the data. So there is a gap in HMIS generation, reporting, and dissemination. For example, if you see during the HMS recording form, they record data on the age social stratifier. But when the HMS data is reported, they only reported the aggregated data. So the social stratifier are lessened. So they send the aggregated data to the municipality and province and federal level. Based on the aggregated data, the annual report are prepared. When the annual report are prepared, the annual report is based on the data disaggregated by province only. There is no data that is shown annual report by social stratifier. So this is the gap in data generation, reporting, and dissemination. So this is the finding of key informant interview. The key informant interview also, from the key informant interview, we found that DIHS is the online platform for HMIS. Like both public and private hospital, they use HMIS for recording and DIS for the reporting the data. So like Dex review, the KI informant also mentioned that the available format in HMIS do not allow to capture wider stratifier. For example, there is quotation like the information of third gender is not available in HMIS, and information of education and the occupation is also not available in the existing MIS system. And also when presenting the data in different platforms, like they focus on the trend of total number of cases. They don't focus on the total number of social stratifiers. Like the HMS data, they are not present on total on the basis of gender, on the basis of age. So there is also gaps in HMIS implementation. Like regarding the availability of HMIS focal person, there is no sanction post available for information management system, and there is no designation position available in HMS for both private and public health facility. So regarding the capacity to use HMS data, so it was found that from the KI like that most of the public health facility and private health facility, they lack the training on the HMIS and they lack the training on DHS tracker. So it was felt need by both public and private health facility that they need regular HMIS and DIS tracker training. So regarding the planning process, so we also check that whether the disaggregated data are used in planning and decision making. So we found during the planning there is a limited use of disaggregated data and municipality like so we can assume that there is a less probability of developing target plan focusing on poor and marginalized group, and health facility do have their own plan. But the planning of the health facility are based on the programming target and budget guidance. And we also, during the interview also, we found that the municipality, they just prepare the plan by themselves. They don't follow the plan of the local government. So this is the planning process. There is the 7 stages of the planning process. So it is generally agreed that the planning process should be participatory. However, our study found that the planning process was not participatory. Only one public, like the public health facility, they were not engaged in the planning process, and also there is no engagement of the private health facility in the planning process. So this is the final slide. Based on my Dex review and key informant interview, we just propose a framework that incorporate gender and intersection variable in regular HMIS. So this just regarding the framework that In the HMS reporting recording form, there should be more social stratifier, and during the data use and analysis, there will be more social stratifier, and also during the planning of the new program, there will be more social stratifier. Okay, thank you very much.